Hello, this is Evan Minty. This is a presentation for Stanford Biomedical Informatics 224 on what we thought was going to be aspirin and CYP2C19, but after a fruitless literature search, we'll look at a couple of pharmacogenes for aspirin and then focus in on PTGS2 or COX2. Aspirin is better known as, or is the better known equivalent of acetylsalicylic acid, first isolated by Bayer in 1897, and distinguishes itself admirably from other products brought to you by Bayer at that time. Motivation here was twofold. One, wondering why some patients could be on aspirin lifetime without any serious complications, while others would get very serious conditions such as GI bleeds. And two, this notion of aspirin resistance or aspirin failure is entering the clinical lexicon, and wondering if there's a pharmacogenomic basis for that. So aspirin is a prototypical analgesic used in the treatment of mild to moderate pain. It has anti-inflammatory and antipyretic properties and acts as an inhibitor of cyclooxygenase, which results in the inhibition of biosynthesis of prostaglandins. ASA also inhibits platelet aggregation and is used in the prevention of arterial and venous thrombosis. The COX-1 inhibition is rapid and irreversible. After a single dose of 325 milligrams, COX-1 is completely inhibited and recovers at approximately 10% per day due to nascent platelet release. Some experts suggest that an aspirin dose of 75 to 81 milligrams per day provides the best safety and efficacy balance for vascular disease and prevention. In terms of potential toxicities, certainly aspirin overdose is a very serious condition. Meanwhile, alcohol appears to cause an increase of 50 to 100% in ASA serum levels, and there are the mentioned gastric side effects that also create considerable morbidity. With respect to the first motivation, there are some potential targets here. For instance, COX-1. This was relatively recently reviewed and won't be the focus of the talk here, but other potential targets with respect to gastric irritation pharmacogenes include CYP2C9, interleukin-1 beta, and TNF-alpha. With respect to this notion of aspirin resistance, the antiplatelet effects of aspirin may not be equal in all individuals. It's a bit of a misleading term because there are likely a number of reasons why patients don't respond to aspirin, such as poor adherence to therapy, drug-drug interactions, so probably is best described as clinical treatment failure rather than pharmacogenomic-mediated resistance per se. There are also very challenging methodological aspects to testing platelet function both in or ex vivo and in vitro, which leads to considerable heterogeneity in these studies. This was probably best assessed by the atherosclerosis risk and community study, which looked at both PTGS1 and PTGS2 and found that the variant 1006A allele in COX1 and 756C allele in COX2 were associated with a higher risk of ischemic stroke events in Caucasians and African Americans, respectively. With respect to an interaction with aspirin, probably one of the more interesting features of that study was that there's a tempting trend towards ASA modulation of PTGS2 C versus non-C variants. So much so that if you redefine your subgroup in a different way, your p-value actually goes from 0.072 to 0.047. COX2 is, of course, best known for its role as a therapeutic target of the COX-2 inhibitors, which also obviously had some ischemic side effects. So the PTGS2 or COX-2 gene encodes for prostaglandin synthase. It has two active sites, a hydroperoxidase and a cyclooxygenase, and hence its common name COX-2. With respect to variants and their distributions, this was reviewed in a PharmGKB summary. The most relevant variant for our purposes is RS20417. On its own, it has mixed results with respect to atherosclerotic plaque risk. There is the C variant was initially found to be protective in a European Caucasian population, though that couldn't be replicated. It was later found to show an increased risk of stroke in African Americans but not whites. And diabetics homozygous for the C allele showed increased carotid calcific plaque, and yet the biggest study to look at it in the context of aspirin use showed a small non-significant association with higher coronary heart disease in aspirin non-users and a lower risk of coronary heart disease in those reporting aspirin use. Accordingly, this level of evidence is assigned a grade of 3 in PharmGKB, reflecting largely that ERIC study. There are other studies, however. This can be referred on your own time, but does show the ERIC study is orders of magnitude larger than other ones that have been done. In terms of clinical translation, this interplay of ASA and COX-2 will be pursued with some interest. COX-2 is potentially even a mediator of the touted anti-cancer effects of aspirin. That has led the authors of the CHEST guidelines to recommend ASA in primary prevention, and this alone will make aspirin use more prevalent than it already is. So on the balance, no clinically significant genetic contribution to aspirin response has been identified, and these are my references. Thank you.